Well, thank you, Jessica, for inviting me to speak today. I'm very excited about this opportunity and hopefully can share some valuable information. So, my name is Jennifer Miranda, and I work at Mountain Pacific Quality Health. I'm the pharmacy case management supervisor, and I have a doctorate in pharmacy, and I'm also board certified in ambulatory care and a clinical pharmacist practitioner. I'm going to be speaking today about stigma surrounding opioid use disorder and some information that surrounds that topic. So let's just get started with, if you go to the next slide, please, the evolution of pharmacists. So I'm sure you're wondering, how did Jennifer get to be a case management supervisor? I didn't even realize that pharmacists could do that. And how did that even happen? So I'll explain. Um, so America had the first licensed pharmacist come here. His name was Louis Duffalo, and he came here in the early 1800s. He settled in New Orleans. And prior to this time, you did not need a license to become a pharmacist. So he settled in New Orleans. He helped a lot of people with his medicinal knowledge. And that sort of set up the precedence for what a pharmacist could do in the United States. And in the about 20 years ago, the requirements changed from needing a bachelor's degree to be a pharmacist to needing a doctor of pharmacy degree. And that helped to expand services of what pharmacists could do out of just the traditional retail setting into more clinical settings that include training on how to run and operate, work on a code blue or a trauma that may come into your office, clinic, or hospital, and also have helped those people that are within the retail setting. Pharmacists have become immunized certified, which means they can provide a multiple amount of immunizations for all different disease states. And as you can recall, when the COVID pandemic first started, it was mentioned that pharmacists would be the best way to get all Americans immunized if they so wanted. Then also, once you finish your doctor of pharmacy degree, you can go on to do a 1 to 2 year residency, which is separate from your 1 year required rotations that you have to do while in college. And you can even go on to do further 1 to 3 year fellowship. You can also apply for board certification, which I mentioned. I am board certified in ambulatory care. What that means is I was certified for chronic disease state management. I did work in a clinic prior to my position here where I was able to prescribe medication and manage certain disease states. Pretty much like the highest risk disease states, which included opioid use disorder and also hypertension, congestive heart failure, abnormal lipids or dyslipidemia, hypertension, things such as that. You can also get certified as a pharmacist to specialize in cardiology, in compounding of medications, critical care, emergency medicine, geriatric pharmacy, and infectious disease. Infectious disease really specializes in HIV and AIDS, among other unique and opportunistic infections. So it really has expanded from the first days where Louis came here. Some fun facts I found in doing this research that I wasn't even aware of when I went to pharmacy school were that Coca-Cola, Pepsi, ginger ale, and Dr. Pepper were all created by pharmacists. And I also didn't realize that Benjamin Franklin was a pharmacist as well. So hopefully that was a fun tidbit for you as well. Next slide, please. So for case management pharmacist specifically, what do we do? So we're looking for a plethora of things, which include interactions between drugs. So that may be, I might be looking for is somebody that's taking a blood thinner, such as the new ones you see on the commercials like Xarelto. Are they taking that with a medication that is used to prevent seizures? One of those is called carbamazepine or Tegretol. That combination will cause the blood thinner to not work, and that can lead to a stroke or a heart attack. So that is important that we're looking behind the scenes for those safety issues and reaching out to the provider and letting them know if we're seeing that. Another type of thing that I'm looking for is the interaction between a drug and maybe a disease state. An example of that might be that medications that are used for anxiety, it's called a benzodiazepine class. You've probably heard of Ativan. That is an example of a benzodiazepine, and that can cause you to breathe a bit more shallow. And then that can lead to actually respiratory depression and respiratory failure, which can be very dangerous, especially if it's in the setting of another comorbid disease state, such as asthma, COPD, or sleep apnea. So what we're doing in my team is we're looking at claims data that comes through and through an insurance, and we're looking at that claims data and we're doing this case management services behind the scenes. Another thing that we're doing is looking at best practices and guidelines. So we do formulate what's called a white paper. So if a guideline changes, like recently there have been the COPD guidelines changed, and they changed when they recommend a particular inhaler and when they don't. And they even changed the classification of where someone should fit into the algorithm of COPD for risk stratification. And we will take those guidelines, we'll summarize them into a 1 to 2 page letter. And the goal of that is to say, this is what's changed, alert the provider, send it to the provider and say, oh, and by the way, we noticed your patient is not on that, and this is why we're recommending it. We try to do that with multiple guidelines for disease states, and we try to make a difference where we can. This information is gathered because we like to provide the provider outreach, which I mentioned, but we also like to provide pharmacy and community outreach for patient safety. So if we notice, say for example, for pharmacy outreach, if we notice that a patient is filling at multiple different pharmacies or from multiple different providers, we would alert both the pharmacy and the provider that that's happening behind the scenes. For provider outreach, like I said, we might talk to them about the guidelines a little bit further than was in our white paper. For example, if we wanted to decrease the use of a rescue inhaler like albuterol that might be being used in asthmatic, we maybe would phone the doctor and alert the doctor that this person is needing a maintenance inhaler to try and control the asthma a little better. And we may also look at other things such as, is that patient getting a lot of steroids prescribed to control the asthma instead of a maintenance inhaler? And if that is true, possibly that patient we notice is also diabetic, and getting that much prednisone can increase the blood sugars further. So we try to look at it more holistically and address all issues if we're reaching out to a provider. And then for community outreach, we do things such as this, like webinars, and we also produce some educational materials such as pamphlets and things that can be used for patient safety. So a little bit of a trivia break here. Can anybody guess, or like a poll, how many people in the United States live within 5 miles of a pharmacist? You can put your answer in the chat. So we have 60%, 90%, and 40%. Let's see what everybody's saying. Okay, got a couple of replies there. So the answer is near 90%. It's 88.9% of people in the United States live within 5 miles, and actually 96.5% of people live within 10 miles. That is for all of the United States. So, granted, in larger places like Texas and Alaska, um, you have to keep in mind that we're also averaging like the small states, such as, on the East Coast, the little tiny states that we have over there. So, this is what makes us the most accessible healthcare professional, and also what led to pharmacists being one of the most trusted professions, is because there's a lot of daily interaction that goes on with the local pharmacists. And another poll question in 2014, what do you think was the most common medication prescribed in the United States? Would you say it's A for lisinopril, B for metformin, or C for hydrocodone with Tylenol, otherwise known as Vicodin or Norco or Lortab? Yeah, and it does look like in the chat that a lot of people are saying C, which is the hydrocodone with acetaminophen, and that is correct. So the most common one was hydrocodone. The second most common was lisinopril. One thing I would probably ask if I was you is, why did we prescribe so much hydrocodone? Part of why we did is what contributed to the opioid use disorder pandemic, as you can imagine. Next slide, please. Thank you. So, factors leading to opioid use disorder. So in 1995, Dr. James Campbell addressed the American Pain Society at a conference and urged providers to treat pain as the fifth vital sign. That is also how I was trained, and I actually trained my family for that. We had a trauma, an accident in the family, and I recall being like, did they treat his pain as the fifth vital sign on life flight? Because that's what needs to happen. That's what needs to happen at the hospital. And this went on, and it was the culture of America, and it's how we were all trained: pharmacists, physicians, nurse practitioner, nurses, LPNs, everybody was trained this way. And then we were also told that by the manufacturers that there was no ceiling dose, and that as long as somebody was still having pain, and they had a tolerance, they'd been worked up on their dose, that the expectation would be that you would increase their dose. So I do remember having a patient that was in her early 80s that was prescribed Oxycontin 3 times a day, and in addition was taking 1 to 2 oxycodone 5 milligrams every 3 to 4 hours. And that was because we were all told that's what you were supposed to do. So that is what we believed. We also were told that pseudo addiction was an actual thing, where if your patient demonstrated signs or symptoms of addiction, it was actually not addiction. It was actually a sign that they were needing a higher opioid dose, which is also why more opioids were prescribed. We later found out that that was not true. We also believed that those that had true pain could not be addicted. I remember getting questions, and I feel sad that I did not have the knowledge that I do now, but I think of the number of people that I counseled that asked, could this be addictive? Is this addictive? And the answer from most of us in the medical field was no, not if you have legitimate, valid pain, then it's used to treat your pain. You won't heal from whatever. If your brain is trying to help with the pain, you're not going to heal, right? So you should take it. And that was education I received in pharmacy school and turned out to not be true as well. Next slide, please. So Yale Medicine, I think, best defines what opioid use disorder is. And they explain opioid use disorder is a chronic disease of the brain characterized by the persistent use of opioids despite harmful consequences caused by their use. I think it's really important that we remember that this is a chronic disease and that it does affect the brain and the brain chemistry. Opioid use disorder is like many other chronic diseases and is often accompanied by stigma. Next slide, please. So the Oxford Dictionary does have some definitions and synonyms for stigma. So they define it as a mark of disgrace associated with a particular circumstance, quality, or person. And some synonyms for stigma are shame, disgrace, dishonor, disapproval, a blemish, a brand, or a mark. There's different types of stigma. There's self-stigma, which is the belief that people hold of themselves, which makes them feel bad about themselves. And then in addition to that, we have public stigma, which is the belief that is held towards a specific group or person. And one thing I would say is, as with all things, history does repeat itself. And I do think that we have an opportunity here to learn from our mistakes. Next slide, please. So an example of stigma would be Ryan White. I'm sure you all recall his name, but if you don't, I would remind you he was one of the first children diagnosed in the United States with acquired immunodeficiency syndrome, or AIDS. He was 13 years old when he was diagnosed in December of 1984. He had become very ill unexpectedly. It took them a while to figure out what was actually wrong with him, and he was given 3 to 6 months to live. That was in 1984. Prior to that diagnosis, AIDS was thought to only affect homosexual men, and he was born with a hemophilia, and AIDS was transmitted to him through a blood transfusion. It took time to diagnose that because he was young and he was not homosexual. The workup for AIDS did not occur immediately. He and his family had to battle through the court system in order to allow him to even attend public school. And on the day that Ryan Wright returned to school after approval from the court system, 27 children were pulled out of his school by their parents and transferred to a new school because they felt that their children would get AIDS just by being around him. Next slide, please. So for AIDS and the stigma and perceptions, I want to speak to that for a little bit. So in 1985, 80% of Americans said it was probably true that most people with AIDS were homosexual men. And 44% of Americans avoided places where homosexuals may be present to avoid contacting AIDS. In 1987, things had improved a little bit, but not much. 51% of Americans agreed it was people's own fault if they had AIDS, and 44% of Americans believed AIDS might be God's punishment for immoral sexual behavior. During Ryan White's 5 years of battling AIDS, he lasted more than 3 to 6 months, he was able to change the face and the stigmas associated with AIDS worldwide. And in April 1990, Ryan White passed away. Next slide, please. So a fact check on stigma and perceptions surrounding HIV. So which race has the highest proportion of HIV diagnosis? If you want diagnoses, if you want to put that in the chat. Which race you think might? I'm not seeing anything yet. Well, the race, African Americans make up 13% of the US population, but they account for 42% of new HIV diagnoses in 2019. So we do have an issue there, a disproportionate amount of HIV diagnoses in the African American population. The other question is, what percentage of new HIV diagnoses in African Americans are women? So thoughts on that? What I'll tell you is Black women account for 57% of the new HIV diagnoses within African American population. So rather high. Which other disease is associated with a high mortality rate in the non-white Caucasian population? And that would be opioid use disorder. A couple of things I want to bring attention to on this slide is that I think the general idea out there is that possibly these things are related to high risk behaviors that are maybe seen by people that are, you know, struggling with a long family history of addiction issues or trauma or things like that. But in the studies, what they found is a lot of this is related to problems with socioeconomic factors. So, for example, this population might have less access to a clinic. There's been studies that show that, you know, in the Bronx and areas like that, it's harder to get to a clinic. You have to take transportation, you might have to take the subway, you might not be able to afford a subway pass, you might not be able to afford a cab or an Uber, you may not have the gas to travel to an appointment in a rural area. And this delays the early diagnosis of HIV. And we'll see as I move forward how it also affects opioid use disorder. Many of these people in this population also lack insurance coverage and can't afford the medication to treat HIV or for the pre-exposure prophylactic medication called PrEP that is used if you are trying to prevent yourself from getting it in the first place. Next slide, please. So the encouraging news after that depressing slide is that knowledge is power. And we do know that new HIV infections fell 8% from 2015 to 2019 after a period of what was general stability. So that's exciting. And it is predicted that we will be able to end the HIV epidemic in the US by the year 2030. So, one thing that we learned through this time is that AIDS was not just a disease of homosexual men. AIDS could not be transferred to someone just by being in the same room. And we also had important figures come forward and make a statement, and it changed the perception of what HIV and AIDS was. So in 1989, as you probably remember, Princess Diana visited the AIDS unit at the Harlem Hospital in New York, where she hugged young children that were afflicted with AIDS. She taught us that we could not get AIDS just by touching someone that had it. We also had Magic Johnson, who was in the NBA, and he was HIV positive in 1991. He was heterosexual. He was forced to retire from the game that he loved, and he became an advocate to reduce stigma related to HIV and AIDS. These were people that helped to eliminate the stigma. And I believe we can do the same regarding stigma surrounding opioid use disorder. Next slide, please. Okay, so next question, if you could put your answer in the chat. So how much more likely is an adult with opioid use disorder to die by suicide? 14 times more likely, twice as likely, 8 times as likely, 10 times as likely. See a lot of answers in the chat there. Thank you. So the unfortunate statistic is they are 14 times more likely. So it's important that we understand as we go through these slides, what are all the factors that increase the risk of suicide in these patients? And I think that'll help us also to decrease stigma and to know how it is best to treat them and what all factors we should be considering when we're treating a chronic disease such as opioid use disorder. Next slide, please. So factors that led to the opioid use disorder stigma was we did have the Ronald Reagan era that I was raised in that was the commercials of Just Say No campaign to discourage children from using illegal drugs in the 1980s and in the early 1990s. I recall when there was this is your brain on drugs, and there was the fried egg in the pan. And I remember thinking, oh gosh, I should never ever do drugs. We then, though, decided that if you were going to use drugs, that you would be criminalized for that and you would be put in jail or prison. And we lacked the ability to think about, why is this happening? And can we decriminalize our way out of an opioid use disorder epidemic? We now know we can't. But at that time, we did believe that. And we thought also that if they were punished and imprisoned, that they would learn their lesson and never use any opioids again, which we now know is also not true. We also believed that addiction was mind over matter and it just took willpower. And that if someone relapses, then they must not have wanted to be sober bad enough. Next slide, please. So, stigma surrounding opioid use disorder does cause a barrier for those to seek care. So, as you can see on this slide, only 1 in 4 people with opioid use disorder will seek treatment. And that is an unfortunate statistic as well. We need to find a way to help improve that. Stigma surrounding opioid use disorder impedes access to treatment and affects care delivery. And it increases the risk of an illicit drug overdose when they're not getting the treatment that they need. Stigma also contributes to the disorder on an individual level. As I said, they already have their self-stigma, and then when they have stigma that's coming from the community, it increases their self-stigma, which makes them not want to go to a provider. And then stigma surrounding other diseases differs from opioid use disorder stigma. And part of that reason is that opioids do affect our reward system in our body and in our brain. And it also affects the way that we can like have a good mood or handle stress. It also can be seen in a higher risk of somebody that has a trauma or a mental health disorder that's often underlying in those people with opioid use disorder. And so that trauma may have affected those brain chemicals to begin with, and then they have an opioid that has changed their reward pathways in their brain. This can lead to a chemical imbalance, possibly even withdrawal symptoms. And some people that are in withdrawal may be acting out aggressively, and they may even steal or acted in an inappropriate way, which then can further affect our judgment of them and our stigma. A commonly held false belief, as I mentioned before, is that willpower should be enough to stop drug use. So I want to reinforce that. And that, next slide, please. Thank you. So again, barrier to treatment. Dr. Nora Volkow, who is the director of the National Institute on Drug Abuse, explains how stigma can prevent people from seeking care and can contribute to their continuing addiction. She says it best in saying that stigma plays an even larger role in this crisis. When internalized, stigma and the painful isolation it produces encourages further drug taking, which directly exacerbates the disease. Also, she brings a lot of attention that resistance in believing that addiction is a disease, that is a new development and way of thinking, probably in just the last 5 years, although scientists have known that to be true for longer. It's taken time to get all of that evidence compiled. And as I mentioned, shame leads to mistrust of providers and avoidance of healthcare. Next slide, please. So Kristen Johnson, you may remember her from the TV show 3D Rock. She is a comedian. She is also part of one of the references that I used, and it's a webinar, not a webinar. It's a podcast called Anonymous People. And she talks about the fact that stigma is deadly. And she says the shame and secrecy is just as deadly as the disease itself. It eats them up. And it's also, as you can see from what shame and secrecy can do to others, it does increase the risk of suicide. Next slide, please. So another trivia question. So stigma prevents what percentage of people with anxiety or depression to seek help? So we have A is 10%, B is 20%, C is 30%, and D is 40%. This is true. You're all getting that right. You all get gold stars or chocolate. If I was in an actual live thing, I would hand out chocolate to you. But 40%. So the effects of stigma are huge, and the fear and misunderstanding often lead to prejudice against people with mental illness and often comorbid addiction, even among service providers. It's one of the main reasons why people don't consider it a real health issue. And this prejudice and discrimination does lead to feelings of hopelessness and shame in those struggling to cope with their addiction, which creates a serious barrier to diagnosis, first of all, and then subsequently treatment and follow up. Next slide, please. So, on a positive note, what can we do? Why are we here today? How can we decrease stigma? So, the first thing I would say is treat people with opioid use disorder as you would those with diabetes. Remember that it is a chronic disease and treat it as such. Remember to avoid stigmatizing language. So, an addict is a person with an opioid use disorder. We do not call a person with cancer a cancer. So that's one of the things we should remember. Also, we should not call them junkies. We should not refer to their urine as dirty or clean. If we're doing a urinalysis, we should say things such as your results were as expected, or your results were not as expected. It showed positive for fentanyl or whatever we would want to be speaking of. We don't want to say they're sneaky, or if they are unable to stay sober, that they were irresponsible or anything such as that. Words do affect morale. We think of how we treat our children and what we teach them about how to treat people, and words hurt. And so it's important to remember that as we grow older, to the lessons that we have learned for years. It affects morale, but it also affects hope and the willingness of someone to seek treatment. For use of harm reduction strategies, again, offering naloxone and improving access to sterile syringes are a couple. We do now have over-the-counter naloxone. I recognize that this is a problem. It's positive and negative. We need to find a way to get over-the-counter naloxone in people's hands. Currently, the price that I'm seeing is $45 for over-the-counter naloxone. And in the patients that I've spoke to, they don't even have $12 to $15. Most of them tell me if it's $10 or less, they may purchase it, but otherwise they'll just take a roll of the dice and hope that nothing happens to them. And so looking for grants to get people naloxone is important to do. And also looking for community events where these can be passed out and you can reach the target audience that you're trying to get to is important. And then continuing to hope that there is continued insurance coverage for those that have a good plan that can get it at a low copay. Recognizing and removing unconscious bias. So unconscious bias is for us to be aware of both the anatomical and physiological mechanisms of addiction. So, as I said, we were trained to think that rehab alone or incarceration would keep people away from drugs, and it didn't. So, we need to work on changing our mentality within. And if they relapse, um, we should be happy that they disclose that to us, and we should be trying to help walk them through how hopefully not to relapse again, and then ensuring that they they survived and that we can hopefully provide further opioid use disorder treatment and support to help ensure that they don't relapse again. And then fostering a judgment-free environment, that can be done anywhere. If there's any pharmacists on the line right now, I would recommend, that in the confidential workspace, that there is counseling given, that you're not afraid to speak to the fact that if you do relapse, I do want you to have naloxone because the chance of fentanyl being in the illicit drug that you're purchasing has a very high chance of causing you to die. I think having those hard conversations in a judgment-free environment is the ticket to helping us to get over the stigma that's associated with this. And also, there's no evidence, there's never been any evidence that shaming people helps them to recover. And I would also say that it's important to educate people around you. So I do know that the universities, and I speak to that in coming up slide, but universities of all states and of all professions are educating people that are becoming professionals on the importance of being positive and treating opioid use disorder as a disease. Next slide, please. So decreasing treatment stigma. So medications for opioid use disorder curb cravings, and they also help with physical withdrawal symptoms, which helps them to not want to seek opioids or other medications or drugs. MOUD also allows the patient time and space to work on what facilitated the addiction. So they're able to take a step back and say, okay, I don't need to go and get my opioid. I don't need to take that. I don't need to be tired from it or sick from it today because I'm being treated. So now I'm going to have some self-focus and maybe some counseling, and I'm going to look on what are my like adverse childhood events or ACEs, and how can I work through that and process that so I can be a healthy and functional citizen. And treating MOUD treatments such as methadone and Suboxone as you would insulin for diabetes. Try not to think of it as substituting one addiction for another. We used to think that, and now we know that's not true. So that's important to carry forward. And that often the need to avoid physical withdrawal is what leads to relapse. So making sure that we're getting medications for opioid use disorder in as many hands of people as we can. And next slide, please. So now I want to focus on disparities that we see in receiving treatment. We talked about the disparities we see in diagnoses of HIV and OUD, but now I want to also talk about the disparities that we see for those to receive treatment. So the state unintentional drug overdose reporting system data from 2019 to 2020 is where I got the following statistics. So there are 25 states and the District of Columbia that have major disparities in receiving treatment. In those states that were looked at, deaths in Black males or African American males were 7 times higher than in non-Hispanic white males. And 16.4% of non-Hispanics had received treatment compared to only 8.3% of African Americans and 10.7% of Native Americans. In the research that I've done, I've also seen these same statistics with in Alaska, with the Alaska Native population, which I speak to here. Next slide, please. So overdose death disparities. I do want to acknowledge, even though this PowerPoint was just done and made available for 2023, data is really behind in the morbidity and mortality weekly report that takes several years to put together. So I didn't have up-to-date facts, but this is the most up-to-date I could find. So in July of 2019, they were able to see that there was an increase in overdose deaths from 2019 to 2020. So we saw 22% increase in white Americans, 39% increase in Native American and Alaska Natives, and 44% increase in African Americans. We also are doing, there's national studies going on looking at those who are incarcerated, and overdose deaths are twofold higher in those that are incarcerated versus those that are not. So it's important to treat our population that's incarcerated as well, including those that are in jail, not just the prison system. Disfavoring a specific population group does lead to stigma, and other high risk factors for an overdose include being a male, having a low income, or recent release from incarceration. It's important then when people are getting discharged back to the public that they have all the tools they need. That includes getting discharged from a hospital, getting discharged from a prison. Next slide, please. All right, so here we are with another question, if you could put in the chat. So in 2021, which state saw the largest increase in overdose deaths? Was it Alaska, California, or New York? So Alaska actually saw the largest increase in overdose deaths, and they are our most rural population, one of our most. I'll speak to that more in a minute. And are more overdose deaths associated with prescription medications or synthetic opioids? I think you all know the answer to that. I think that's a gimme. You would have got more chocolate here too. But yeah, it's synthetic opioids. So next slide, please. Alaska saw the largest increase with an increase of 75.3% in 2021, which is quite staggering. In the United States, 2.7 million people suffer from opioid use disorder. And in 2021, we saw almost 81,000 overdose deaths related from opioids. And in 2021, we also saw a 15% increase in US drug overdose deaths. As you can see on this slide, the number of deaths, the highest that we're seeing is from synthetic opioids, which is fentanyl. And now we also see carfentanil in some of these deaths. That wasn't spoke to in this report. As you can see on the bottom column, we have our prescription opioids. So of everything that people are overdosing on, our actual prescription opioids are less of a culprit. Next slide, please. Treatment disparities, some potential causes of treatment disparities that I've already somewhat alluded to, but I may have some more in here, are some of the same things that prevented people from going to get to a clinic to possibly get a diagnosis of HIV. So we have the secondary effects of income inequality, which could include unstable housing, homelessness, unequal insurance coverage, and unreliable transportation. We can also have the healthcare disparities, which is decreased access to healthcare, which also affects access to getting treatment for opioid use disorder or any other healthcare. Insufficient resources. So earlier I mentioned the opioid use disorder may be a long distance away. It may have to come at a cost of gas money. And we also have a lack of support networks. So who is going to watch my children when I go to the clinic? I don't want my kids to hear or see what is being discussed. And I don't have any family to help me, or maybe they are also addicted and not able to help me, or maybe I can't afford daycare or a babysitter. And then we have the intergenerational trauma. We have alcoholism, drug addiction, mental health, etc., that may be contributing. And we have discrimination. Next slide, please. I want to bring attention to the age disparities I see in the elderly. I think that we often think this population is not the population that has opioid use disorder because they weren't, they're not on the streets. They're not wanting to try something. They found ways to deal with their trauma differently or whatever. But the statistic is that we do have opioid use disorder in this population, and they are a high risk for suicide as well, the elderly population. We this is a group that I was speaking to, that when I first came into being a pharmacist, that I would say, no, you can't get addicted to that. And now we know that to not be true. And this age group had the carpet pulled out from under them. And we're told, now we know it is addictive. So now you have to get off of it. So a lot of these people have had to resort to seeking to get an opioid. So it's important to recommend that, or to recognize that. And it's also important to know that data is lagging and it's conflicting and ever changing. So that's why I don't have a lot of numbers on this slide. But what I can tell you is I can speak to it from a pharmacist perspective. And what I worry about is the chronic conditions that are in the elderly that also increase the risk of an accidental overdose. So we have a decline in organ function, which could be the kidney or the liver, that metabolizes the medications. So that can increase the levels of the medication, which then can increase toxicity or respiratory depression risk. They also are higher risk for COPD and sleep apnea. So that is important to think about. We also have polypharmacy. They are, as we age, we unfortunately end up having to take more medications, and the more medications we take, the higher risk we are for a drug interaction. So again, that increases the risk of respiratory depression. If I have somebody that has COPD and also has anxiety, and they're getting like Ativan or a benzodiazepine, and they are also taking an opioid, they are much higher risk than somebody that does not have COPD and is not taking Ativan. And with the issue of aging, we also have more chronic problems, or acute situations, I should say, that can come up and lead to a chronic problem, such as a hip fracture or a cancer diagnosis. So the diagnosis that would require a prescribed opioid does increase with age. And so maybe somebody didn't have opioid use disorder, but they're going to, because they tried an opioid and it caused them to have pleasure, caused an addiction, then it caused brain chemistry changes and a domino effect. And so we do need to be cognizant that these are people that we need to be looking out for and protecting as well. And then we have a decline in cognitive function. Both dementia and Alzheimer's can increase the risk for an accidental fatal overdose. Important to consider. And next slide, please. So what about our youth? So when I think of youth, and I think of like 18 to 25, maybe those in college are probably the highest risk, and I used to think, for opioid use disorder. But we also need to not forget about our younger age group, those age even down to 12, up to age 25, because they are engaging in higher risk behaviors. They are more likely to believe they are invincible, and they truly trust their friends completely. So we can discuss with them many things as their parent or their pharmacist or their provider, their counselor, but they will trust their friend more than they trust us. So it's important to continue to educate and to continue to put in safeguards to try to protect them from an accidental overdose, which I'll discuss in the next slide. Next slide. So what can we do? So we can lock up prescriptions at home if you have them. Make sure you keep them locked up. That doesn't just include an opioid, that includes anything that could be unsafe. So, you know, if you have, like I said, benzodiazepine or something that could cause harm if they were to take it with an opioid, we should be thinking about that and anything that could really actually cause an overdose. I have friends that lock up their Tylenol from their kids, and I don't necessarily think that's a bad idea. So locking up prescriptions at home is a safeguard that you can take. Keeping medications out of sight. It may not be you or your family that has a problem, but you may have a caregiver that's coming in and out. You may have a very large family. My mom comes from a family of 9. You may have a lot of people coming in and out. So it's important to think about that. It's important to talk to your pharmacist. So um, for offices for aging, the senior centers, make sure that you're connecting with as many groups as you can and that there's a presence there where there's an expert that can help these people. Also, don't hesitate to, if you have somebody that you're concerned about that is a family member or a patient of yours, don't hesitate to ask a pharmacist to look for drug interactions, which include over-the-counter products. It's important, as I mentioned, when we are elderly or even young and we don't metabolize things the same as middle age with our kidney and liver issues. Kids are usually hyper-metabolizers, so they're just going through it quickly. But all things can affect the other. So if somebody is having an issue with their kidney, it can increase the risk of a problem or an opioid overdose. So, oh, sorry, I need to go back to that. And the other thing is when discharged from a hospital or a nursing home, schedule counseling on what to do if you develop cravings for an opioid. So have a backup plan, like think forward. Here you go, you're going into the scary world. Maybe you just had a hip fracture. Make sure you're explaining to them this can happen. You can develop an addiction. And if you start to have cravings for these things, here is your action plan. Don't exclude a whole group because you don't think it'll happen to them. Same as for our children, you know, a lot of education should be happening in the junior high and high school area. There should be parent conversations and school conversations and hopefully one day peer conversations. And I would also recommend that care coordination between medical facilities. So if you're getting out of the hospital, make sure that there is a follow-up appointment for your patient set up at the clinic where they're going to be going. And if it's like on a Friday and they're not going to be seen for a week or two, I mean, that's where we're at right now with a shortage of medical staff. Make sure that there, like I said, is an action plan for those people as well. And then I also want to remind everybody that we still do need to treat pain. I do feel that the pendulum has swung, as it always does in medicine, 100% one way. And we do need to remember that it is still important to treat pain. We just need to be educating differently than I used to on the risks associated with it and what to watch out for signs and symptoms of addiction. And we need to be prudently prescribing and monitoring. I did unfortunately have a 90-year-old that broke her hip and went to the nursing home without any pain medication because the hospitalist did not want to prescribe it, doesn't ever want to prescribe anything that could cause a chance for an opioid addiction, so won't prescribe at all. I feel like that has gone too far the other way because that is kind of you know, inhumane a little bit. So I was able to get a hold of the primary care provider and get that ordered, luckily, but it's important that we try to remember that as well. So for next slide, please. Holistic health care. So what percentage of the United States medical schools offer holistic health care courses? A is 25%, B is 40%, C is 50%, D is 80%. I see a lot of A's. So yeah, even better though. We're at B, 40%. Well, actually C, sorry, 50.8% of medical schools. So what I can tell you is the exciting part is when I worked at a clinic is I had a medical resident assigned to me and my pharmacy student, and we were a team, and their medical director of the clinic was also involved, and we presented cases together as a dynamic duo. So As a pharmacist, the pharmacy student would have to present on what the provider would need to talk about or think about, and vice versa. The medical student or resident would have to present on what a pharmacist should be thinking about. And then we would get together after and pull it all together and teach one another. So it's a really interesting dynamic that's happening out there, and I'm excited about it because how to use a pharmacist is being discussed, and then ways to look at holistic healthcare and empowering the patient to be at the center of care, like in patient-centered medical home model, and how not to just be narrow focused and look at one thing, but look at all the factors we should be thinking of when it comes to patient care. Next slide, please. So this quote comes from Camilla Venner, who is a PhD assistant professor at the Department of Psychology at the University of New Mexico. She's also a member of the Athabascan tribe. So she said, we think of addiction as a brain disease, and that is a great way to reduce stigma and help people get the treatment they need. But putting the brain at the center of everything is a narrow way of thinking. We need a more holistic approach that goes beyond a person's biology. We must integrate culture, societal factors, and even spirituality, when appropriate, into mainstream medical institutions and education. Next slide, please. So this goes along with what the National Institutes of Health, or NIH, also endorse. So they came up with a model, and this specific model was how to integrate MOUD with the healing traditions of American Indian and Alaska Native communities. But they said it was important that we don't just look at the physical or biological issues, which include healthy lifestyles and behavior, tapping into traditions, and incorporating physical strength and conditioning. But it also includes the emotional or social aspect, which is talking to the person about how they feel in regards to security, autonomy, accomplishment, identity, and their integrity. And then the mental or psychological aspect, which is the ability to set boundaries and use teachings to solve problems and help them learn how to problem solve correctly. And then spiritual, and it doesn't have to believe in a particular God, but just natural laws, principles, and values, and participating in cultural practices and ceremonies. Next slide, please. Some successful programs that I want to touch on today and tools. The first, and most of this slide comes from the Wellbriety Training Institute, which is an institute that uses both Western and Indigenous worldviews. So if you think of Western, I visualize that as a ladder of, and the studies say that Western views believe that the humans are at the top, but like the frog and the plants are down at the bottom, but we're superior. And we sometimes think of treating opioid use disorder as a ladder instead of as a circle. So in the Indigenous worldview, as a circle, we are all equal, no matter where we are for socioeconomic status, or if we are a frog or a plant or a human. So they believe as everything is a circle. They believe recovery is a process and not an event. And they also have talking circles, which I'll speak to, but those talking circles are used to validate individual thoughts, feelings, and opinions, because there are many that are taught through their culture and their childhood ACEs, not to trust, not to talk, not to feel, and the experience in itself can be healing. So what they talk about in the talking circles is, first of all, they have rules, and they say no one can interrupt. Everybody gets their chance to talk. One person speaks at a time. And this helps for people to find their voice. It helps them develop a feeling of security, a feeling of autonomy or independence, and it gives them the initiative to not be afraid to take a risk to talk. And once they talk, they usually end up having a feeling of accomplishment and that they were feeling good, that they, being good at something, they were being good for something and good at something. It also gave them identity, a feeling of knowing who they are, and intimacy, or a feeling of belonging and connectedness. We also have, in those talking circles, they have what's called generativity, which is the feeling of being able to give back with what they have learned. And integrity, a feeling of confidence, which I think is huge, is to give people confidence. And what would you do if, when no one is watching? Like, think about your confidence, so that when you're not in the circle, what are you going to do when you're at home? And then it's also important because all of those things contribute to positive mental health. And next slide, please. So the healing forest model, it's important that we think about how to create that. And what the Wellbriety Training Institute has done is they have an idea. The idea is that a forest is that of a forest, like a community, is only as healthy as its roots and environment. And unless individuals, families, and communities are provided with a means of overcoming the impact of the unhealthy, dysfunctional root system that is also associated with anger, guilt, shame, and fear, they will find themselves participating in unhealthy behaviors. And I did include in this slides, you'll see at the end, I do have a link to this, to their website. Next slide, please. So the Digwalik Wellness Center is in Washington. Excuse me, it's the Swinomish Tribes Wellness Center. And the reason I wanted to speak to them is because they have reduced overdose among tribal members by 50% in just 1 year. So the mission is to remove barriers to treatment, to treat the whole person. I love that mission. I think it's great. Holistic, and they do have everything under one roof. So they have primary care, they have mental health, chemical dependency, and an MOUD treatment area. This has helped to decrease stigma, which is their goal. That is one of their primary goals. They also provide free transportation. So they ensure that their bus driver is empathetic and always available. They have multiple bus drivers, and because they recognize that the bus driver is going to be the first person somebody sees. They also have social worker. They meet with a case manager weekly to help to teach life skills to help them. And that helps to remove childcare, stable housing, and transportation as obstacles. They do have transitional housing, and they do have an on-site childcare system. They have found that they are better able to get to appointments, which helps them succeed at recovery. They've also learned job readiness and meet with financial management team. They have team meetings, and they try to ensure that the needs of the patient are being met. The important thing I also wanted to say is in the first year, they had a 77% retention rate in their program, which is unheard of. And of the 23% that fell out of the 100%, everyone in the 23%, the commonality was that they had housing insecurity, which made it hard to maintain consistency with treatment. And they recognized that they had to address the housing insecurity, which is how they came up with transitional housing for men, women, and families. So lastly, next slide, want to say that I want to end with a quote from the 14th Dalai Lama, Gwalala Rinpoche. He said, "Love and compassion are necessities, not luxuries. Without them, humanity cannot survive." So I want to make sure, I think that's huge. I think the world can be a better place if we all think like that. I will leave an opportunity for questions next slide, if you could go to the OUD documentaries and resources. These are some of the resources that I use that I recommend on this slide. And then I do have two more slides, actually three, four, four more slides of references that I used. So thank you for attending today, and I'll open it up to any questions.
And feel free to unmute yourself or put them in the chat.
Right.
I'm not seeing any, but we will leave the chat open for a moment. But before we do that, I do want to let everyone know that we have a survey for today's training for Jennifer's wonderful presentation, and we would sure appreciate you filling that out before you jump off. Margie just pasted that in the chat. This really helps us to not only improve, but it is something that for our funding is really, really important for our reporting. So if you wouldn't mind filling that out, we'd really appreciate it. And again, we will stay on for a couple minutes here. So if you have any questions, you can unmute, throw them in the chat. And if you are going to leave, we sure appreciate you joining today. And keep an eye out. We will be sending out meeting materials shortly. And Kathy, I did see your question about certificates. You can absolutely get a certificate. I'm going to pop my email in the chat here. If you need one, please reach out and I will send that to you.
Yeah, thank you for everybody for joining. I hope that it was informative, and maybe it'll spur some good discussion later.
Lots of thank yous in the chat. And if you do think of questions after the fact, we can certainly get those to Jennifer too.
Yeah,
to
I can
connect
put
you.
my email in the chat as well.
Thank you.
Yeah.
And Deborah, I did see your paste, so I will get you a certificate out. All right, everyone. Well, we sure appreciate you coming today, and thank you, Jennifer, for the wonderful presentation. It was an honor to host you.
Oh, well, it's an honor that you asked me. Thanks so much. Let us know if there's anything else we can ever help with, and any questions any of you have, feel free to absolutely reach out to me. I'd be happy to try to answer them.
Thanks, everyone.